Okay, looks good, and we are recording. So there you go. Do you want this? Do you want to?
You can leave it.
Yeah, we'll throw it up there, and then if something comes up chat-wise, you can see it right there and kind of follow. Okay, there you go.
All right. So we talked to Dr. Brownlee. When was it? Last Friday. Last Friday we talked to Dr. Brownlee.
Yeah, here you can take off and I'll wear it so that
It's okay.
they can hear you better.
I don't know. But we talked to Dr. Brownlee, and so we tried to pick all the high points out for you guys. So basically know the differences between the histology of the bone and cartilage. So the hyaline is the most common and the hardest. Be able to distinguish things like what's not common between the three types. So like the perichondrium isn't present in the fibrocartilage. That would be something important to note, where they're located. And he said, well, you know how they always put pictures, gross pictures of things on the side of a question. So like know a yellow gross appearance for elastic cartilage or a pearly white transparent appearance for hyaline cartilage. And especially the where hyaline cartilage is located. That'll be very important. So fetal skeleton and then the articular ends and epiphysis. So just read over this. Proliferation of chondrocytes. So just know it's a slow growing malignant tumor and it rarely metastasizes, unlike the osteosarcomas. And something important about the osteosarcoma is that the most common type of osteosarcoma is one that metastasizes due to lung, breast, or prostate cancer. So that's something important to note. Most of them aren't primary bone tumors, meaning it originated in the bone. If you were to see a slide, one thing he made note of is the pleomorphic cells. That would be something important to note. And the osteoid is the pink around the like a circled red you see. Osteoarthritis, so wear and tear disease. So unlike rheumatoid arthritis, you're not going to see inflammation, and it's not going to have a genetic factor to it. We put the X-ray findings, so you won't see this joint space. It'll be uneven. I think normally it'll be favored on one side, unlike the rheumatoid arthritis, which it'll be equal on both sides. But look for the osteophytes. So here circled in blue, that's an osteophyte. Subchondral sclerosis. So you see how it glows white. That's due to increased collagen. So that would be something to look for. And then especially just, I could see him putting a picture of like just a narrow joint space, just bone on bone. Another thing to note with clinical symptoms is that it's going to worsen throughout the day. So you'll present as like joint stiffness, and then it'll get worse throughout the day. Whereas rheumatoid arthritis, it's going to get better throughout the day. So that's an important distinction to make. So here's rheumatoid arthritis, mainly females. And here's the HLA-DR4 is the mutation. So you also got this pannus formation. So I don't know if he'd put this on there, but that's like one of the highlights of it is this granulation tissue that leads to a pannus. It's like a keyword. And then arthritis with morning stiffness, that's going to improve with activity. Bone, so just know it's type 1 collagen. External layer is periosteum, internal marrow cavity is covered by endosteum, and then you have the three major types. So you're going to want to be able to find those on a slide and know the difference between them. So especially know like the different origins. So osteoblasts come from mesenchymal cells, osteoclasts from monocytes, and then osteocytes from osteoblasts. And then the function of each, remember that it's osteoblasts that control the osteoclasts by the secretion of MCSF, which helps it differentiate into the pre-osteoclast, and then the rank L to stimulate the osteoclast activity. Another key thing that he wanted us kind of just note is he has a specific histology slide on like the house ship lacunae. So probably wouldn't be unlikely for him to ask a question. What cells are in the house ship lacunae? So osteoclast. So that was one thing as we were going through slides he pointed out. So just knowing the functions of each of those and how to differentiate them, especially know like osteoblast or simple cuboidal, that'll be helpful. Osteoporosis. So this I think is going to be talked about more on the second exam, but it definitely comes up a lot on this exam. So just know a loss of trabecular bone mass, resulting in porous bone with increased fracture risk. So he made the example of like astronauts, how astronauts, since they don't put any weight on their bones, it affects the cells because they work as like mechanoreceptors. So it leads to more osteoclasts breaking down bone. But just remember, it's a loss of trabecular bone mass resulting in porous bone with increased risk of fracture. So senile people who aren't moving a lot, weightless astronauts, aren't getting that osteocyte stimulation. So that's one cause. And then postmenopausal women, because estrogen is protective. So if you lose that, it can lead to osteoporosis. So you may want to look for like older women. If you saw that in a question stem, might be osteoporosis. So, and then no abnormal labs. When we look at osteomalacia, it's definitely gonna have abnormal labs. So that's one way to differentiate those two. And then the DEXA scan is a good way to look at bone mass density to be able to tell how at risk someone is for fractures. Woven bone, in his lecture, he basically said it was going to be a question. So first type of bone to appear during embryonic development and fracture repair. So yeah, he pretty much said that was going to be a question. So just remember, it's the first bone put it down, the immature bone or the primary bone, and then it's replaced eventually by a lamellar bone. Yeah, just cortical compact bone is the outer region, made 80% of lamellar bone. And then just know the different definitions, like cancellous is the same thing as trabecular and medullary bone, and it'll make up 20% of the marrow cavity. With these pictures, he said, I don't know, like you'll probably still have to know the structures of things inside them, but he said the big thing was going to be knowing the different types of cartilage. So being able to differentiate each type of cartilage will be very important. With the fibrocartilage, you're not going to have a perichondrium. And with hyaline cartilage, you're not going to have a perichondrium at articular surfaces or the epiphyseal, but you'll still have it everywhere else. So definitely look for that. Elastic cartilages, you'll see the elastin fibers. And with the fibrocartilage, you're going to see a lot more of the extracellular matrix and cells, chondrocytes lined in rows. So that's something to look forward to. So endochondral ossification, I put this slide because I didn't know if he wanted you all to know the different zones. He said it's not important that you know the different zones, but to tell the difference between endochondral and intramembranous, just look for these zones. So here you've got the zone of resting cartilage, the zone of proliferating cartilage right here, and then it just goes on down. So if you find the different zones, then you know it's endochondral ossification. He said you don't have to know like where each specific zone is in a slide section. For intramembranous ossification, just look for the spicule. That'll be your key there for that. So for bone, you got to know the different structures. So you'll have the caniculi, you'll have the Volkmann's canal that's transverse. Lacunae is where the osteocyte sits. And then the osteon is the whole unit as a whole. And then the center can be the central canal, or it's also called the Haversian canal. So either one of those. All right, so here's from the SDLs. Kind of just tried to pick out the important points for y'all. So myasthenia gravis is very common. Lambert-Eaton is not common. For myasthenia gravis, you're going to have antibodies against the acetylcholine receptor, whereas in Lambert-Eaton, you're going to have antibodies against the voltage-gated calcium channels, so you can't release acetylcholine. In a question sim, you would probably see like an enlarged thymus or thymoma for MG. So like one of the treatments would be to take out the thymus, since it's actually the thymoma, since it's actually creating the antibodies against the acetylcholine receptor. And then if you see a question sim associated with small cell lung cancer, that's key for Lambert-Eaton syndrome. So when you see clinical symptoms, ptosis and diplopia, so you'll probably see like a drooping eyelid or a blurry vision with MG. You're not going to see that with Lambert-Eaton syndrome, more than likely. And a way to distinguish Lambert-Eaton from MG is the autonomic dysfunction. So the dry mouth, constipation, and impotence. You won't see the autonomic dysfunction in MG. So keep that in mind, those two differences. But you can see proximal muscle weakness in both of them. It's just more common in the Lambert-Eaton. So a good treatment for MG is anticholinesterase agents. So that way it allows the acetylcholine to stay in the synaptic cleft longer. So even though you have antibodies against the acetylcholine receptor, you can let the acetylcholine stay there longer, and that should provide treatment for that. And for Lambert-Eaton, just removing the tumor should resolve those symptoms. So a big thing is knowing the antibodies that are against each receptor, and also what it's associated with, like a thymoma or small cell lung cancer. So here's just like a chart to help kind of summarize everything. So another thing that's important is the muscle use with myasthenia gravis. It's going to get worse with use, whereas with Lambert-Eaton, you're going to see improvements. So that's also very important. And then you also notice what we talked about, the autonomic symptoms aren't present in myasthenia gravis, but they are common in Lambert-Eaton. All right, so botulism, key thing, I just put the 5 Ds. So descending flaccid paralysis, dysarthria, dyspnea, diplopia, and dysphagia. So when you have the snare proteins, they try to bind with the vesicle containing acetylcholine to the presynaptic membrane. So what botulism does, it prevents the formation of the vesicle with the presynaptic membrane by cleaving one of those snare proteins, and that prevents the release of acetylcholine. So the big thing you would want to look for with infants is ingestion of spores, and the big thing there is honey. So that's like key thing is ingestion of spores, whereas in adults, it's going to be preformed toxin. So that's a key difference. So canned goods. I'm looking at a question here. Is MG specifically postsynaptic? MG is specifically postsynaptic because it attacks the acetylcholine receptors, and acetylcholine receptors are on the postsynaptic membrane. LIMS, Lambert-Eaton, is going to be specifically presynaptic because once you get an action potential, it causes the release of calcium into the presynaptic membrane. So those calcium channels, those voltage-gated calcium channels, are on the presynaptic membrane. So yes, they are specific.
That might be in the questions.
Yeah. So yeah, definitely probably in the questions then. So yeah, just knowing honey and the ingestion of spores, the 5 Ds, and the preformed toxin in canned goods should be good for botulism. Organophosphate intoxication, so inhibition of acetylcholinesterases. So if you have no acetylcholinesterases, you're going to have more ACH in the synapse. So that can just cause a lot of overactivation. We talked to him about inflammatory myopathies. So the big ones he said were dermatomyositis and the polymyositis. He really acted like the others weren't important when I brought them up. So there aren't slides on them. So if anyone wants to kind of confirm that, they can, but I took it as it probably won't be on the test. And I couldn't find it in the step book or any Pathoma or anything. So with these, the important thing is dermatomyositis. It's an inflammatory disorder of the skin and skeletal muscle. It's associated with carcinoma. I think that's actually one of the quiz questions, is which one's associated with carcinoma. So dermatomyositis. Clinical features, so you're going to get the proximal muscle weakness. So this could be like you can't comb your hair, you can't climb stairs. The three big skin lesions you'll get is the heliotrope rash. So you'll see that on your upper eyelids. Gottron's lesions, so red papules on the elbows, knuckles, and knees. And then the malar rash seen in lupus as well. So you got to be careful to distinguish between those. This picture up here on the top is due to the paramecial infiltration. So you'll notice right around here, the top, the paramecium is what's infiltrated by CD4 cells. So that's a key key feature to look at. And then you'll get increased creatine kinase because it's doing muscle damage. And you'll also have the positive ANA and anti-Jo1 antibodies. So I'm pretty sure that's the take home from those. Yep. Polymyositis. So you won't see like the heliotrope rash, the malar rash, the Gottron's lesions. It's a disorder of the skeletal muscle, not the skin. So you'll still have the proximal muscle weakness. You just won't see any skin involved. But here you see the endomesial infiltration around the myofibers. So infiltrated with CD8 instead of the CD4.
Yeah, and that's really important distinguishing between these two, CD4 and CD8. So make sure you have those as well.
So skeletal muscles, just note being able to distinguish skeletal muscle, cardiac, and smooth muscle is important, mainly looking at being able to see each one on a slide. These diagrams, he basically said no very well, because basically if you know these diagrams, you'll be fine on the test for the content. So yeah, I put these on here, but these are just for y'all to look at, because he definitely made a note of them to make sure y'all know those. This slide, so just the slow type fibers are gonna be dark staining, intermediate gray staining, fast type white staining. So, you know, he probably wouldn't ask just like what is dark or what is light, but he'll ask you something about one of the slow type or fast type fibers. So just be able to distinguish those. Tendon versus ligament, just being able to distinguish those, he said was important. What was the best way, he said, to be able to distinguish?
Oh, you have the fibers. If it's a good stain, you have fibers.
Yeah, so hopefully it'll be a good stain and you'll be able to see those fibers. He said he will try to give us really good pictures. So just being able to know the difference between those. So on the left, that should be your tendon, and right should be the ligament. So achondroplasia, so you have a defect in cartilage proliferation at the growth plate. So remember, it's a gain of function mutation. That's important. So FGFR3 gene is important to know. It's a gain of function mutation. So FGFR3 normally inhibits endochondral ossification. So when you get a gain of function mutation, it'll inhibit it even more. And it's a sporadic autosomal dominant mutation. Clinical features, so short extremities, normal size head and torso. I've seen some things that said that the head is actually smaller, but I would go with normal size head. Just remember that the intramembranous ossification is not affected. So you'll see that Tyrion has a normal skull, chest, and wrist, whereas the endochondral ossification is defective because it's the mechanism of long bone formation. So his long bones are what are affected. Osteogenesis imperfecta, so autosomal dominant mutation. Okay. Make sure, just so we don't get.
Yeah, so thank you, Emily. Like, you can definitely see more cells.
Yeah, so the one on the left is the ligament. Yeah, the one on the left is the ligament. And you see the elastin fibers, so the dark purple, gray. Sorry, I mixed these up on the, like I put tendon versus ligament, but the one on the left is the ligament, the one on the right is the tendon. And on the ligament, you see the elastin fibers. Is that kind of, okay, yeah, sorry. Okay, so osteogenesis imperfecta. So you have a congenital defect of bone formation resulting in weak bones. It's due to a defect in type 1 collagen. I don't know if you need to know the exact mutation, but just remember COL1A1 or COL1A2. It's an autosomal dominant mutation. So you're gonna have short stature, multiple fractures, and bony deformities. Mnemonic you can use to memorize it is BITE. So you're gonna have bone fractures, you're gonna have the, sorry, it's I for eyes, but blue sclera, dental imperfections, and then your tiny ossicles in your ear. Small bones are very prone to fracture, so you're actually gonna have hearing loss. Osteopetrosis. So this is an inherited defect of bone resorption because you have defective osteoclast. So this is due to carbonic anhydrase 2 mutation most of the time. And it's an inability to form the ruffled membrane. So basically, if you remember the equation for carbonic anhydrase, you use CO2 and H2O to form carbonic acid, and then that'll form bicarbonate and H+. So bicarbonate leaves and leaves H+, but every time bicarbonate leaves, it pushes that equation forward, generating more H+. So that H+ is what helps make that acidic environment. So what's defective due to the lack of the acidic environment from the osteoclast, you could have abnormally thick bones. So I could definitely see him showing like an x-ray or something, that bright white. You'll get anemia, thrombocytopenia, and leukopenia, which cause pancytopenia, which kind of just means everything because you have filling in of that marrow cavity so that you can't form red blood cells, platelets, or white blood cells. You get the hepatosplenomegaly because then you're forced to perform extramedullary hematopoiesis since the cortical bone is actually filling in your marrow cavity. And then you'll also get hearing or vision loss because these bones are growing out and they can pinch nerves. Marfan syndrome. So no, it's an autosomal dominant disorder. No, it's causes the FBN1 gene mutation. So these people, just think of like Abraham Lincoln, Michael Phelps. They're tall with long extremities, long tapering fingers and toes, and they have hypermobile joints. And the most common cause of death is going to be your aortic dissections and rupture because this has heart problems associated with it. And the EDS syndrome, it's an autosomal dominant or recessive disorder. So you'll have the hypermobile joints, the classical type, which is joint and skin symptoms, and then also the vascular type. So just knowing the three types, I think, is important. And then the mutation in type 3 pro-collagen or the type 5 collagen will be important. Rickets and osteomalacia. So this is a defect in the mineralization of osteoids. So remember, osteoblasts, they lay down osteoid, not bone. So you're still having osteoid laid down. It's just not mineralized by the calcium and phosphate, which is what's defective. So causes will be the decreased sun exposure. You get around 90% of your vitamin D from the sun, which helps in the absorption of calcium and phosphate. So without the vitamin D, it's hard to absorb those vitamins and nutrients. So a poor diet can also play a factor, and malabsorption after surgery. So if someone just had a procedure or something removed, that can play a factor. And then liver or renal failure. So remember, rickets is in children and osteomalacia will be in adults. And so the big things you'll see with kids and rickets is going to be the pigeon breast, the rachitic rosary, which is what the picture shows below, and then the bowing of the legs, so Genuvarum. You won't really see that. We asked Dr. Brownlee, he said you won't really see those as much with osteomalacia. The big thing is pseudofractures, and with both these, you're going to have bone pain, but the big thing is going to be the pseudofractures. And with these, you're going to have abnormal lab values. So that's something very important to note, is the decreased calcium, which is going to cause your increased PTH and decreased serum phosphatase, and then the increased alkaline phosphatase. Okay, and so now this is where Nicholas is going to pick up on muscular dystrophies. Does anyone have any questions about that? I went kind of fast, but we've got questions and stuff, which I'm sure is what y'all care about more. All right.
All right, so moving into muscular dystrophies. Throw your answer in the chat. So these are example of neuro or myopathy changes in muscle. This might be a key image for you guys if you guys remember this part right here. See if anybody throws their answer in the chat. So all of them are grouping. How had that checkerboard appearance? No guesses? You got a 50% chance. I like 50%. Myopathic. Nice try, Jordan. These are all neuropathic changes. Okay. So number one, you got the angulated fibers. So this is first section is understanding myopathy versus neuropathy. And just also being able to distinguish type 1 fibers versus type 2. That was actually covered in lecture previously, but here it comes up again in this SDL. So big things here is when you see these two stains right here, okay, we have the fiber type grouping. So type 1 fibers, if they lose their innervation, well then when the nerves kind of re-go back, they just grow back in these sections and you lose that checkerboard appearance. Here are targeted fibers. That's not really covered where we are in angulated. It might just come up once. We don't have these pictures in our SDL, but I just wanted to make that kind of with especially the fiber type grouping. So, so neurogenic, you have the type 1, type 2, you got the red, high mitochondria, myoglobins, slow twitch, long-term aerobic. So make sure you have the type 1 versus type 2, be able to just, whenever you hear type 1, to come across all that in your mind. You should normally have the checkerboard appearance, but if there's a injury to the muscle and it's neurogenic in its pathway, then you're going to have this, you're going to lose your checkerboard and have type 1 type grouping. So they lose that appearance. Yep. All of them, or just, I would say I'd say it's kind of depend. So the osteoporosis, if you remember that one, it's the X-ray of the really bright, whenever we were at that, there it is. So kind of this image right here, it's very characteristic of osteoporosis. Petrosis, sorry. So I would definitely know that one.
We asked him if all the pictures we have in our PowerPoint, if they know, we said if they know those pictures in the PowerPoint, are they good? And he said yes.
Yeah.
So take that as you will.
Yeah. He said all the pictures in here were very helpful. So, I mean, these first two, I did not get these directly from here, but this one right here, the grouping, I would definitely know this one right here on this page. I think that would be important. Okay, cool. So it's neurogenic and then myopathic. You got segmental necrosis, which is simply like the cytoplasm stains paler than the visual fibers. So this just means, okay, there's necrosis whenever you have myopathic changes in muscle. Myophagocytosis, you have the presence of macrophages, muscle fiber regeneration. So they're going to be that dark blue kind of smaller fibers that are regenerating. And we'll see a picture, an example of that coming up. Central nucleated, multinucleated cells, just know ring fibers and fiber hypertrophy, and this would be like working out. Some of those bodybuilders don't really need to associate a picture with that. Then we go into toxic myopathies. So there's 4 of them. I would just pick up the main ones from each one. So you got your statin induced. You're gonna have big one for this is you're gonna get to renal failure, and it's also you're gonna have symmetrical and proximal muscle weakness. And if you take a biopsy, it's going to be necrosing, inflammatory infiltrate. Your glucocorticoid, you're going to have muscle atrophy, you're going to have no pain, and you're going to have specific type 2 fiber atrophy. Chloroquine induced, that's for treating RA or SLE and malaria. The problems with this is you're going to have toxic effects on type 1 muscle fibers. And so like you just saw here, okay, glucocorticoid, that's type 2. Chloroquine is going to be type 1, and then muscle weakness as usual. And then your last one is alcoholic. So you're acute, you're going to have muscle pain, fiber necrosis, and elevated CK. And then your chronic, because it's going to be over a long period of time, you're not going to have that elevated CK in the chronic. And this is going to be more selective for the type 2, and it's going to be entire muscle mass reduced over time. And just think about the, if we go back into the effects of alcohol on the liver, and so you're going to have inhibit the protein synthesis. So that's why you're hitting those type 2 fibers, especially overall. Okay, here's another question. This is, yeah. So 47-year-old male is in the ER for pain everywhere and is instable and unable to stand up from a seated position for an unknown time frame. Patient is, sorry, I can't see that, is a poor historian. Patient labs show elevated CK and poor renal function. Here's your muscle biopsy. What the patient is most likely has a history of what? So this is going to be second order, where you got to think about, okay, what did we just cover? The toxic myopathies, and thinking about, okay, what does statin treat? What does chloroquine treat? So we kind of go through our answers, and we will choose. Oh, I don't have the answer on here, but this is going to be B, hypercholesterolemia, and I'll come back up here and explain. So statin induced, it's going to be for treating that. You have that renal failure, and you have fiber necrosis and infiltrate. So come back down here, we have fiber necrosis and that inflammatory infiltrate right in here as well, and trying to regenerate those muscle fibers, and also elevated CK and the poor renal function. So poor renal function should have really stuck out to you right there. Any questions on that? Okay. So yeah, just remembering, okay, statin treat lower your lipids, and so then that would be if they have hypercholesterolemia. Kind of the second order question, a little bit harder. History of statin. I don't know. It's a good question. We will see. Like maybe they will give us statin, maybe they won't, and we have to deduce that. It isn't here, so I would kind of be ready to kind of just go ahead and get your mind taken on that. Muscular dystrophies. So here we got inherited muscle dystrophies of the skeletal muscle, and we're going to talk about Duchenne's and Becker's. Just dystrophy in general, we have progressive muscle weakness, degeneration, and typically in the DMD, you're going to have childhood, and then BMD, it's going to be later onset and it's less severe. So big thing for DMD, it's more severe, more common, and usually you have spontaneous mutations, although we will see that it is X-linked. So muscular dystrophy, the dystrophin gene, and we can see right here, the brown area right here, this is immunohistochemistry, and you can see positive stain for that, that'd be normal. Here, you do not see the brown surrounding these muscles, and that's a problem, and that'd be pathogenic, okay? And that would be, and the biggest thing for this is the X-linked inheritance pattern. So when we talked to him, he said one of the really big things for especially these diseases in here is knowing how it's inherited. So if it's autosomal, recessive, or X-linked. So I'd highlight that for you. Dystrophin is important because it provides mechanical reinforcement for the sarcolemma. Why is that important? Sarcolemma holds all of the calcium. And if you have less of that, then your sarcolemma breaks open, you get calcium release, and that's going to lead to apoptosis as well as necrosis. So that cellular death of these muscles. Starting with DMD, biggest things. So DMD, you should be able to get Duchenne's, and you got dystrophin. You have deleted. So you're typically going to have a frame shift deletion. That is really big for this one. X-linked disorder, frame shift. Growler sign, that is this image right here. You have the kid trying to get up. He struggles to get up normally, so he has to get on all fours here and kind of walk himself up just because of that weakness. The second is hypertrophic calves. Calves are these muscles right down here between your knee and your ankle. Loss of dystrophin, and you have elevated CK because your muscles are being damaged, and aldolase. DMD. So here is what I was talking about earlier about the, here's your regenerating muscle cells. So regenerating muscle cells, it's really basophilic. They are blue. And secondly, you also have these eosinophilic ones. This one's probably about to die, different sizes. So these are little, these are big. And then this is going to be late stage. You're going to have that, you're going to have fat cells, adipose tissue here taking the place of the muscle cell. And that is really what muscle dystrophy is. So necrosing fibers, that one's probably necrosing right there. And then these are regenerating right here. This is gonna be early, and this is gonna be later in the disease. BMD Becker is better. So it's not as bad, later onset, and partial dystrophin protein loss. You're gonna have a non-frame shift mutation. Lab findings, you have elevated CK because your muscle cells are dying, aldolase, and lactate dehydrogenase. Myotonic dystrophy. So we have inherited multi-system affecting skeletal muscles and smooth muscles. So we're also going to have high eye, heart, endocrine, CNS issues. Myotonia is abnormal electrical activity of a repetitive action. So you're gonna have a decreased power to be able to relax your muscles. And there are two types. We're gonna go through both of them here, and they're both autosomal dominant. So myotonic dystrophy, autosomal dominant. So DM1, you're gonna have a couple of these things over here. You're gonna have that trinucleotide repeat, so CTG expansion. What I really like about this is you can make that into mnemonic. You have cataracts, toupee, and gonal atrophy. But the biggest clinical takeaway here is difficulty releasing a handshake. That's going to be huge. See that should be your trigger word to get to know this. I would say this DMPK gene probably important here. Go ahead and know that as well, and notice how it's distal muscles. So when you Difficulty releasing handshake, that should clue you in on DM1. DM2, this should be the tetra. Let me get to my notes here. Tetranucleotide repeat. This one's going to come later. Both of them have anticipation because we're talking about these repeats. They are expanding. You usually have like less than 30 or less than 70 of these, and they expand up to the hundreds or thousands. So you're gonna have prominent facial weakness here and inability to release hand grip. And this is DM1. So both these slides are on DM1 here. So autosomal dominant DM1, dilated cardiomyopathy. That's the mainly how they die. So that symptom's related to that. DM2, we got the tetranucleotide repeat in the ZNF9 gene. Also have anticipation in DM2 as well. Clinical symptoms appear earlier in life and are very severe. Okay. So DM2 presents in the third decade. I think it says earlier in life, but that's due to anticipation. Sorry, anticipation will make it earlier and more severe. That's the concept of anticipation. And then DM2 presents in the third decade, so presents later than DM1. And has the same proximal weakness, but is more, has a slower progression. So kind of look at the age range of the patient to kind of distinguish between these two. I would say it's less high yield to know the differences between the two of these, but still kind of pick up, okay, DM2, less severe and it's later onset. Pathogenesis, I had 3 genes here earlier and you'll see them in the notes. He said knowing the genes for the kind of later genes for this is not as important, but no, it's gain of function mutation and it's inhibiting the muscle like protein, and that's going to be regulating the RNA splicing. So you're missplicing certain genes within cardiac muscle and skeletal muscle. And it's kind of knowing those specific genes right there are not as important. EDMD is X-linked recessive disorder. There are 2 versions that are autosomal, but it's mostly going to be X-linked. You know, mutations in the LMNA gene is most likely the mutation gene for it. Anti-Imurin antibody staining will show no staining. So you have absent Imurin antibody, or yeah. And they are at higher risk of cardiac death. Okay. All these are, you will see this in your boards books. It's not as important. These are typically low yield, but we still need to kind of go over these for the exam. So Imurin, so the EMDM has Imurin, and that's in the nuclear membrane. Laminins are intermediate filaments, and the X-linked EDMD is staining for this anti-Imurin antibody, shows the absence of normal nuclear membrane. So that's characteristic of EDMD. The oculopharyngeal, biggest part for this is the levator pulmonary muscles in the pharynx. So you have ptosis and dysphagia, remember the eyes. Autosomal dominant and or autosomal recessive, and caused by expansion of the guanine cytosine in trinucleotide repeat in the PABN gene. The fascioscapular humeral, this one's really nice because in its name, it's telling you scapular humeral, autosomal dominant, winging of the scapula. So if you can get that from the name, you're doing great. I would go ahead and remember DUX4 as well as the expression protein for that. Limb girdle muscular dystrophy. So you have the progressive muscle wasting, autosomal recessive and or dominant, the CAPN3 gene, and this occurs between 16 and 18. So I would just limb girdle, you're going to have, I'll go ahead and go to the next kind of summary slide for this. Just know, hey, like they're going to have an unstable girdle here as well as pectoral girdle. And just be able to distinguish, okay, where is each one of these taking place? If I said winging scapula, you should be able to go straight to the facial scapular humeral muscular dystrophy. This is a pretty good summary slide for these dystrophies. These are also low yield right here, but I just kind of put them all here. You have central core disease, histochemical stains for oxidative enzymes showing lack of staining for core region. So caused by the RYR1 gene, and it's the calcium channel, and it's autosomal dominant. Pneumoline myopathy, you're going to have these presence of the minute rod structures within the muscle fibers. Affected genes encode the thin filament within the skeletal muscle of the muscle sarcomere. Centronuclear, you have the muscle fibers with central nuclei that resemble myotubules, and you have the absence of these myofibrils. And then the congenital fiber type disproportion, the small type 1 fibers on the muscle biopsy, mutation in the ACAT1 gene. So then these two are really important. He stressed these as well, the hyperkalemic paralysis versus the hypokalemic paralysis. So starting with this one, you have the SCN4A gene. What I'd say the biggest thing for here is knowing voltage gated sodium channel. That is huge for this one, caused by calcium rich foods. I didn't put it on here, but two things, let's see. This is the hyperkalemic. So hyperkalemic is short lasting, and the hypokalemic, the next one, this one is longer lasting. So this one lasts about minutes to hours, and it is autosomal dominant, which is, both of these are autosomal dominant. Both these are autosomal dominant. High potassium, so potassium rich foods, and you're gonna have, it's gonna be short lasting and sodium channel. Hypo, you're gonna have, should be the subunit. Yeah, calcium, there it is. The calcium channel. So it's really important for the hypo is calcium channel, low potassium, and these are gonna be longer lasting. Okay, and that is it for those resources. We included some resources here. Of course, your Quizlets, you got Andrew Yoon, Madison Battersby, Taylor Wilson. She's a second year, made some of these if these haven't come out yet. I've already been going through these, they're really good. I would recommend Robin's Cotran review of pathology that is available for us in the drive, and fundamentals of pathology. So these two kind of books right here are highly recommended to be able to help. This will help you, especially with histology right there. And then other resources, Quizlets, Wade Hooper. Wade Hooper's he's like a couple years past. He would actually make lectures over these SDLs. You can go look him up if you'd like to. WebPath has great practice questions. Ninja Nerd also has great practice questions. But let me see if I can pull up some practice questions. Yeah. No clue. How many questions are on the exam? We don't know.
We can email.
We can ask. Yeah, we'll let you know we'll follow up with an email. Share screen. Okay, and then we're just gonna send these questions out to you. I got them from Robin and Cotran. You should be able to see them. So kind of went through here with the question, and then followed that up with, okay, this is what it is, and there's an explanation. You can find most of these in Robin Cotran. These are all the ones that are relevant to what we've gone over. I think in the X-linked ones. Yes, I think so. I would agree with that. Any other questions? Okay, so we will send this out to you on Slack. And if you have any questions, we will also have another review session tomorrow. We're going to cover the last two SDLs and also kind of see if we can get some more questions, as well as go over.
Find out more things about the exam from Dr. Brown. And we'll
yeah, so after our little review session, we'll go ask him a bunch of questions and put that together for you guys. Anything else? Share. All righty, that's all we got for today. Y'all have a wonderful study evening. Yeah. Oh, yeah, yeah.
Sorry, we'll have to get it figured out.